Deborah Work-Zode. I'm the Deputy Executive Director of the Global Fund. It's both an honor and a privilege for me to introduce our first speaker. You know, he is the 42nd President of the United States, the first Democrat to be awarded 2 terms in 6 decades, and the leader whose administration created more than 22 million jobs and presided over the longest period of economic expansion and prosperity in the US history. But there are some things you might not know about Bill Clinton, the private citizen. He started one of the fastest growing NGOs in the world. Today, the Clinton Foundation has staff and volunteers worldwide. Thanks to his leadership, 2 million people living with HIV/AIDS around the world are now receiving the medicine they need to survive. The Clinton Global Initiative has brought together thousands of world leaders, top business executives, Nobel laureates, and innovative thinkers to take action to solve some of the world's most pressing problems. To date, the Clinton Global Foundation members have made 1,700 commitments valued at $57 billion, which have already impacted more than 220 million lives in 170 countries. 40 cities are working with the Clinton Climate Initiative to reduce their carbon footprint and make a significant impact in the fight against the global climate change. The Alliance for a Healthier Generation, a partnership between the Foundation and the American Heart Association, is putting a stop to the rise in childhood obesity in the US. Alongside former President George Bush, President Clinton helped raise more than $130 million to help people along the Gulf Coast recover from Hurricane Katrina. After the tsunami in South Asia in 2004, he teamed up with President Bush to raise more than $10 million for relief efforts and served as the UN envoy for tsunami recovery, overseeing the region's efforts to build communities back better, and they were before the wave swept them away. Last year, President Clinton was named the United Nations Special Envoy for Haiti to assist the people and the government as they built back better and set out implement their economic vision for the future, building on President Clinton's long-standing commitment to Haiti while in the White House and his work through the Clinton Global Initiative. Following this year's devastating earthquake, President Clinton continued to work alongside the government and people of Haiti through the Clinton Foundation. In addition, President Obama asked President Bill Clinton and President George W. Bush to raise funds for immediate high-impact relief and long-term recovery efforts. In response, the two established the Clinton-Bush-Haiti Fund. I think we can all agree the world wouldn't be the same today without President Clinton's more than 35 years of public service. Please join me in giving him a warm welcome. President Clinton.
Thank you very much. Thank you. Thank you very much. First of all, I want to thank Deborah Work for the introduction. I want to thank Anya and Vujaseka for speaking earlier. Jean-Marc, thank you for representing the EU here. To Nora Volkan and my friend Aline Gale, I know your part of the program is after I leave, but I want to thank you. There are many people in the audience, probably hundreds that I've worked with over the years. But before I begin my remarks, I have to say that I will attempt today to speak for the people who work in our NGO, CHI, and I'm very grateful to all of them, to our Magaziner and Anil Soni and Ed Wood and all the staff that work all around the world, many of them in countries where they live, to try to help save lives. Many of our funding partners are here, but the other night at the local Age Life event, two of our partners in Cambodia, John and Carol Tucker, were there with 8 Cambodian children who participated in the event, who are alive today because of people like you. And I want you to know, I've been here in every meeting since 2002. And it seems now that I've spent a lifetime, which is a long time for me, going to meetings where people said wonderful things about whatever it was they came to meet about. And then what happened afterward never matched their words. Here, there's a lot of action to go with the talk. And that's why I came again. And I will continue to come as long as you'll have me. I want to thank you all for persevering through what is a challenging time. When we were in Mexico City, we knew then that the economic crisis, which was sweeping the globe, would challenge our ability to get the needed funding, both public and private, to keep the AIDS movement going. A lot of you have done a remarkable job dealing with that crisis, and I thank you for that. I also think that we know quite well that there is still a lot to be done. This year's conference theme, Right Here, Right Now, reminds us that health care should be a right for everyone, but isn't. Notwithstanding the current economic difficulties, the evidence of the progress that has been made in the last few years is not an excuse to walk away from that right. It's an excuse to run toward it for all of us. Just think what's happened since 2002. Increased investments at the most rapid rate applied to any public health problem in human history. In the last 4 years, going up from $6 to $16 billion. Donor aid has been the primary source, but we also have something relatively new. Broad-based giving by private citizens in huge numbers and large amounts, manifested most clearly for me by Unitate, which is coming up on its 4th birthday. It began with a simple, small airline tax on all international travel in and out of France. Now 28 other nations make a contribution to Unitate every year. Some from the airline tax. Norway kicks in a little from the carbon tax. Other people find other ways of doing it. But I want to say to all of you, I am profoundly grateful. Now, the countries who have not found it feasible to contribute or to pass an airline tax are being given the opportunity to participate through a voluntary nonprofit arm, which has been called Massive Good. It was announced formally as being up and running just a month ago, so we haven't raised much money yet. But essentially what happened is 3 of the biggest airline bookers in the world, online bookers, have given us a box people can check when they book an airplane ticket to make a small voluntary contribution. One of the things I'd like to ask all of you to do is to do what you can when you go home to get more people to buy their tickets at one of these places and to check the box. We have a big public relations job to do, but if we did it, I'm convinced hundreds of millions of more dollars a year could be raised easily from people who knew they had this user-friendly option. Project Red has flourished by allowing people to buy products that give back. They've given $100 million to the Global Fund. All of this is rooted in the simple idea that the best way to raise private money, once you get past Bill Gates, is to raise a massive amount of money in small amounts from a huge number of people. But to do it, you have to make sure they know what the option is and it's reasonably user-friendly. I am really, really excited about the potential of this and profoundly grateful for the work that we've had a chance to do with our foundation, CHI, with Unitaid. They asked us to try to negotiate lower prices for second-line drugs and pediatric AIDS medicine, following up on the work we did with first-line drugs earlier. And look what's happened. The second-line medicine has gone down from about $1,000 to $425. The children's medicine, when I started, was $600 a person a year. Then it dropped to $190. Now it's down to $60. The new first-line combination, even though the least expensive first-line drugs are about $90, the new one, it's just one pill once a day, has dropped in price 70%, to less than $200 per year. So we're doing pretty well. 5.2 million people are on treatment, about half of those under prices that our foundation negotiated. And that 2.6 million is up 70% from the time we met 2 years ago. All of you know that the incidence of HIV globally is down 17% this decade, but it's worth pointing out that the progress is even greater in places where people have taken a real determined step. And I think all of us are thrilled about the new direction in South Africa. But it's worth pointing out that women aged 15 to 24 saw a reduction in HIV incidence of 60% over the last few years. So I'm thrilled about that. I'm thrilled that there are now 300,000 children on treatment and that we are closing the gap that once was a yawning chasm between adult and childhood treatment. Another interesting thing that I want all of you to know about is that our foundation, which primarily deals with generic drug producers in India, South Africa, and a handful of other places, negotiated its first agreement this year with a big American pharmaceutical company, Pfizer, which makes a drug that, as far as we know, is the only one you can take if you have AIDS and tuberculosis to treat the TB that doesn't make you so sick you can't function. They gave us a 60% reduction in the price right from the beginning. And this, for those of you who are familiar with the drug wars in America and elsewhere, this was quite a departure from past practice. So I asked the new president of Pfizer, Jeff Kendler, I said, why are you doing this? And I could tell he didn't expect to be asked that. And he smiled. He said, first of all, it's the morally right thing to do. But he said, secondly, we don't have a sustainable business model. We cannot possibly go out 50 years just marketing all our products to 10 to 15% of the world. We ought to sell to 100% of the world. And in order to do that, our unit costs have to go down. That was the best news I'd heard in a long time. So I hope we can build on that in the years ahead. Along the way, a lot of us over the last decade have formed remarkable partnerships. The Global Fund has been instrumental in this because NGOs get about half the money from the Global Fund, and they're represented along with people living with HIV and healthcare providers and governments in the deliberations of the Global Fund. So I'm very grateful for that, and I think it's been very important to our success. I have to say, just by way of personal indulgence, because of my experience in Rwanda, Malawi, and Haiti, I'm especially grateful for our partnership with Partners in Health and Dr. Paul Farmer. And if you want to help Haiti to build its first national health system ever, number one, don't let anybody tell you it can't be done. Don't let anybody tell you the Haitians don't have the ability to do it. And if you want to help, see Paul Farmer before this is over. I hope I have made a lot of work for him on this. I also have to tell you, as a non-scientist, I'm very excited about what we have learned in social science research. The first time I heard about the first circumcision study, my instinct was it would work. And I was cautioned not to just go half crazy and advocate it all over the world until we had some proof. Well, we now know things we didn't know 2 years ago. We know circumcision reduces transmission in excess of 50%. We know treatment can reduce transmission by 90%. We know we have new tools that just 2 years ago we didn't have, new drugs and point-of-care technologies that bring care closer to people who need it. CHI helps accelerate how quickly these new technologies get out there in places like Mozambique, thanks in no small measure to Irish Aid. We're working with the government there to use new point-of-care diagnostics, a simple handheld machine that can tell someone in any remote rural village right then and there what their CD4 count is. If we're going to use the CD4 count for determining when to start treatment early, we need these machines in every rural place in the world that can have it. I also want to say, as most of us in this audience know, before this meeting is over, there will be some very encouraging news on the scientific research front, and I believe there will be more in the next couple of months. I just want to say, I think the microbials will get better. I think that we'll get closer to a vaccine. I think we'll get closer to easy to take other preventive mechanisms. All this is good. But to paraphrase what Winston Churchill said when the British finally started winning a battle or two in World War II, this is not the end. It's not even the beginning of the end. It is only the end of the beginning. In other words, we've ramped up. You've done a great job. But we have to transition now from what has essentially been make it up as you go along emergency response to one that we can sustain. 5 million people on treatment is a lot compared to where we started, but still just a third of those who need treatment today. We cannot get to the end of this epidemic without both more money and real changes in the way we spend it. I think it is profoundly important that we think about both. Now, for whatever it's worth, this is what I think we should do, and I will do my part. First, obviously, this is a replenishment year for the Global Fund, so the donors need to replenish. Second, in every country, we need to fight the temptation to present the choices involved in a way that really creates a false dichotomy. The current debate in the United States and elsewhere in the G8, between treatment for AIDS and maternal and child health and building out health systems is a movie we have all seen before. It just had different characters. First, there was the choice we had to make between treatment and prevention. Then people figured out that if they couldn't get any treatment, why should they practice prevention? Then there was the choice that we were supposed to have to make between kids and adults, because even though there were fewer materials in children's medicine, the numbers were so different that the cost would always be higher. Now, it's much lower. Then there was the choice between effective prevention for drug users and continuing to take a stand against illegal drug use. And now we know that the more we provide effective treatment, the more drug use goes down, not up. Every single choice Look, there are real choices and hard decisions to make. But if we're going to make hard decisions, they ought to be real choices, not false ones. The facts are on our side. Let me just give you an example of why I don't think the choice between putting people on treatment and doing more in maternal and child health or building stronger health systems is a real choice. It's not a coincidence that we have 35% fewer children dying every year now than 20 years ago, or that maternal mortality has dropped by 20% in the very same decade in which the Global Fund and PEPFAR channeled more money into global health than ever before. The fight against AIDS has raised a lot of boats. To fight tuberculosis and malaria, to improve health systems, to challenge and motivate governments and NGOs alike to deliver more and better health care. Fighting AIDS in the right way clearly improves maternal and child health. In the work we do at our foundation on PMTCT, our first measure is not an AIDS indicator. It's whether or not we're increasing attendance of pregnant women in prenatal care and rates of women delivering with a skilled birth attendant. Seeing those numbers rise will lower the number of children born with HIV and advance maternal health. And it works the other way around. If you invest in maternal health, you're going to lower HIV transmission by educating girls on reproductive health, getting them into care when they're pregnant, helping them to deliver at a clinic or with an attendant. If you invest in children's health, you'll ensure infants are coming in to get vaccinated. If you have HIV diagnosis available when they do, you can increase coverage rate for pediatric AIDS treatment. We all know the fight against AIDS is also a fight for improved health systems. When I was in Tanzania last month,
В прошлом месяце я был в Танзании, в одной из 57 сельских больниц, которые мы там построили, где обеспечивается стерильность инструментария, где есть собственное энергообеспечение за счет солнечных батарей, где...
And the child was, as a matter of course, screened for HIV, and thank goodness was born HIV negative. We don't have to worry about treating that child, but one reason we don't is that the child's mother is part of a healthcare system that can take care of her, and every mother like that in that area that needs the medicine to prevent mother-to-child transmission can get it. So I don't think these two things are in conflict. Now, there is a real choice to be made, but it's not the one we've been told about. For example, if you really want to increase healthcare systems and to increase treatment, we have to have more qualified healthcare workers. Africa has 10% of the world's population, 25% of its health burden, and 3% of its healthcare workers. We need more people in the healthcare workforce. Specifically, we need people who can do good work at lower cost over a wider geographic range than doctors can do alone in poor countries, or than doctors or nurses can do alone. In Zambia, we've worked with the government to add 1,000 healthcare workers in less than 18 months. This didn't take very much new money. What it took was different organization and determined local leadership. We also shouldn't have to choose between treating people in the developing world and the rise of HIV again in countries with higher GDPs. AIDS remains a real challenge in America. Prevalence among black men is 3%, and AIDS is the #3 killer of African American women in their prime. And the economic crisis has also hurt domestic care. The Federal AIDS Drug Assistance Program has also not continued to keep up with demand, and even in the United States, for the first time in years and years, there are 1,600 people on waiting lists in a dozen states. Recently, President Obama announced a new focus on our domestic challenges, and I'm encouraged by that. But I would also like to say that the domestic drug manufacturers in America who provide our medicine have been paid for years now at roughly $10,000 a person a year. And they have recovered an enormous amount of their costs. They could take care of those 1,700 people tomorrow, fairly allocate the burden, and never miss it. And I think that's what they should do. Now, let me say, of course, we should do the things I said, and of course they will require some more money. But I think there is another false choice that it would be easy for us to avoid. We also have to change the way we do what we do. The world is awash in troubles. It is easy to rail at a government and say, why doesn't the government give us more money when they're giving somebody else money? But the government gets its money in most of these countries from taxpayers who have lower incomes today than they did 2 years ago. So if we're going to make this case, they have to believe that we're doing our job faster, better, and cheaper. And then we have the moral standing to go ask people to give us more money. So I want to offer a few observations on that. And I'd like to start with a few comments about the controversy over PEPFAR funding. That's a great thing about not being president anymore. I can say whatever I want. Of course, nobody cares what I say anymore, but I can say it anyway. But I really do want to talk you through this. A couple of months ago, Bill Gates and I were invited to testify together before the Senate Foreign Relations Committee on President Obama's proposal developed by the State Department, by Hillary and our new AID director, to invest more money in building health systems around the world. And both of us said in different ways that we supported the legislation, but we didn't think the AIDS funding should be held down. And we made most of the arguments I just made to you. But let me just talk a little bit about what happened and offer some observations on what to do. First of all, I completely understand why the advocates for greater AIDS funding have loudly protested. But I do not think it is either fair or accurate to say the president has gone back on his promises as if this was a callous walking away. When he signed that proclamation, that petition saying he would support greater AIDS funding, it was before the American economy led the world into the worst financial crisis since the Depression. Since then, he has tried to keep his commitments. Even I read all the right-wing tabloids and blogs at home, all of his words, even his worst critics will admit that he tries to keep his commitments. That's why they don't like him, because they disagree with what he's doing. But in the last year and a half, we have passed a massive financial stimulus bill, dramatic increases in investment in alternative energy, lowered the cost of a college education by providing direct loans. Just the other day, financial regulation to stop these excesses from occurring again, and a sweeping reform of American health care. This is a man who tries to keep his commitments. The budget reflects what they believe was the limit that Congress had put on overall health care assistance spending. And the pressure that the United States government and the G8 got from the governments of the countries where we work to spend more money on health systems and maternal and child health. Now, what we have to do, therefore, is to deal with that fact. You have two options here. You can demonstrate and call the president names, or we can go get some more votes in Congress to get some more money. My experience is that the second choice is a better one and far likelier to pay off. There is no way the White House will veto an increase in funding for AIDS. And so I appreciate how frustrating it is. And as I told all the folks who are involved in this, I said, the problem with this position, and I realized they were in a terrible bind, but sometimes I had to do this. Sometimes by prior arrangement, I would meet the House budget ceilings. For example, I would always put more money into early childhood education, and believe it or not, it was in the same budget as the National Institute of Health. And then Newt Gingrich, of all people, would put more money into medical research, because even our Republicans want to live forever. And then in the end, because nobody wanted to be seen as cutting education and everybody wanted to be seen as being for medical research, they simply raised the cap. It was a deal. We could work something like this, I hope. Maybe it's harder now that I told you what we did. But I just want to say, I think in the end, everybody will have to come around to this, because if they pass more money for maternal and child health, they're going to find more mothers that need the PMTCT treatment. If they do this, they're going to find more kids that need ARVs. And if they build more healthcare systems, I can assure you, based on our experience in Ethiopia, in Zambia, in Malawi, in Rwanda, and every place we work, they're going to have a lot of people showing up for treatment. And who wants to build a nice new clinic that is nothing more than an office where someone says no? Thank you very much for coming in. Here's your health status. Now go away. So we're in a very difficult position here that we can work our way out of over the next 2 or 3 years. But I just want to urge you not to assume the bad fate of the White House or the administration. The director of PEPFAR, Dr. Ari Goolsbee, is here. He had the guts to come here. He ought to get some kind of Purple Heart for showing up. Stand up, Eric. Give him a hand. Hey, now what I want you to know is, this is important. This man is your friend. He's been working on AIDS since before maybe the youngest people in this room were born. He went to China for our foundation to set up the AIDS program we did in rural China. He is a good man. The other thing you need to know is that, well, just last week, he released new guidelines confirming that our funds can now be used for needle exchange to prevent HIV among injection drug users. And finally, you need to know that the U.S. held off 1 year longer than most of the major European contributors to the Global Fund in shaving the contribution. But the European countries, I think, would like to do better too. So, and as all of you know, or many of you do, the new director of AID in the State Department formerly worked for the Gates Foundation. He is your friend too. So I think you should have a joint strategy. And I think you should lobby the Congress. And I think you should educate people about not making a false choice. And I think that is a far more effective strategy. Now, then the second thing I would say is we have to remind ourselves that more of the same is not good enough. Yeah, we've made progress on prevention, but we don't do very much on it. And we know the AIDS epidemic won't end with the treatment options we have now. It will only end when we stop new infections and no one dies before their time. We're not doing enough ourselves. First, we have to do treatment better. Specific drugs that can keep people healthy even when they aren't on ARVs. Better integration between HIV and TB therapy. Amazingly, these two diseases, although they are most often coincident in one body, are still treated separately in most places. We need better and more durable combinations of drugs and testing that is simpler and quicker. We have to do prevention better, too. We have to scale up what works. I'm thrilled that we now have indisputable evidence that circumcision works. We also have indisputable evidence, and Bill Gates will talk more about this when he speaks, that all these cultural things we were told about how African men will never show up and do this turned out to be flat out wrong, that there's more demand for it than we thought, but there's not enough supply yet. And it has to be done in a safe way. So we have to do more of it, and we should invest more money in it. We have to target the right approaches to the communities based on the source of the highest rates of transmission. There are too many places where the main source of transmission is still men having sex with men, and the political apparatus acts like it's not happening. They're in denial, or there's got to be some sort of stigma attached to it. Meanwhile, people get sick and die. We have to do something about that. There are too many places where the main source is injection drug use and there's no political constituency, so the first time there's a bump in the road, it's easy to cut them off and think it's their own fault, in spite of the fact that, as I said, I will say again, all the evidence is if you do substitution therapy and clean needles, drug use goes down, not up. So we need strategies that deal with the real issue. And we need to translate the latest science, not just in pilot projects, but on a broad scale. And this again cuts against flatlining either the Global Fund or PEPFAR, now that we know that treatment may be the best prevention strategy we have. The numbers are very, very high. So, that's really important. Look at the people who just were up here speaking before me. In Europe and Central Asia, the AIDS epidemic is driven primarily by intravenous drug use. We know what works: harm reduction. And Our foundation, for example, works in Ukraine, and we've helped to get methadone moving there. But nobody's done it to scale. And we can no longer say we need to let 1,000 flowers bloom and pretend everything works as well as everything else. We got evidence now, and we don't have all the money in the world. We should find what works. The third thing we have to do is to cut the cost of delivery. And I want to say a little about this. This is one of the things I guess I can do since I have been president, and therefore I was partly responsible for this for a period. In the last decade, we developed kind of an emergency model of aid, channeling money through established organizations in respective countries that had fairly high upfront costs to get things started. I think we need to change to a model where we fund national plans in developing countries more directly, with more funding to the governments and to local organizations who can deliver services well at far lower cost and less overhead. I think in too many countries, too much money goes to pay for too many people to go to too many meetings and get on too many airplanes and do too many to provide too much technical assistance. Too much is spent on studies and reports that sit on shelves. And maybe when we got all the money in the world, this is regrettable but not tragic. But keep in mind, every dollar we waste today puts a life at risk. It is time for the United States to lead the way and for other governments to do similar soul-searching and hard-headed analyses to see how we can take a higher percentage of every country's foreign aid budget and actually spend it in the countries that the money was appropriated for, on the people the money was designed to help, instead of on the apparatus in the country in question. And as I said, I don't want to blame anybody, and I don't necessarily think there are any demons here. I was president for 8 years. I had no idea this was as bad as it was. I was always attacked for knowing too much about the budget. Turns out I knew too little. But we can fix this. And the next thing I'd like to say is I think we should help other countries who know they should change their own delivery systems. I mentioned that we've done work in other places, but we should be shifting tasks, in any kind of new healthcare system, from doctors to nurses where possible, and from nurses to traveling community health workers where possible, to spend the money more wisely and to deliver health care in a better and more timely way. A number of governments are making real strides in this direction. South Africa, as we all know, has shown remarkable leadership this year. They're now trying to test tens of millions of South Africa and more than Africans, and more than double the numbers on treatment over the next few years. It is more than double the number of health systems providing AIDS treatment in the past 4 months, and will redouble the number of centers again in the next 6 months. And we have been privileged to work with them on something that surprisingly is still not universal. The work the CHI staff did with the South African Health Ministry is going to save them $280 million a year in paying for their AIDS medicine, the same at the current volumes. And they'll save about $45 million a year on their lab and testing. That money can all be plowed right back in to more treatment. So I would say it's not right for anyone here, unless you really do know, to assume that all medicines and all commodities have already been purchased at the lowest available price. And I just saw President Zuma when I went to South Africa to check on some of our programs, see Nelson Mandela as close as I could to his birthday, and I did see a couple of World Cup games too. Well, I can tell you something. Jacob Zuma is proud that his country is no longer a pariah in the fight against AIDS. And I'm proud they found a way to save more than $300 million to put it into increasing treatment. The third thing I think we should do in this area is to challenge African and other governments when they come into vast sources of new money to put some of it into their own healthcare system. There is enormous wealth in Africa. There's enormous wealth in Central Asia. There's a great article the other day saying there may be $1 trillion of wealth under the ground in Afghanistan. Long as the world population continues to grow, there'll be more drilling and more mining, even if we reduce greenhouse gas emissions by 80%. People will go after every conceivable kind of mineral and metal. And I am terrified that people are going to go in, economic interests from outside African countries are going to go in there and make big bids and offer huge amounts of money to go mine whatever it is you find in these countries or drill whatever oil they have, and that none of it will go to benefit ordinary people, or that the money will all be spent on infrastructure or even on education. It is we, in this economic climate, with this many lives riding on it, if we do our part and we give as much as we can, if a windfall comes into these countries and they have not built a big funding base, it is acceptable to ask them to do what Rwanda and some other countries have done, to kick in what they can, and only what is fair to ask. But I think it's a mistake to pretend that they shouldn't own some of this. And a lot of you know where this has not happened. I think we all have to examine our own organizations. Bill Gates talked to me about this problem of limited funding and rising need for treatment last January, and we promised to do what we could to lower our own delivery cost, and we're working on it. We thought we were doing about as well as we could, and then we realized we could do better. We all should. I think those of you who come here primarily as donors need to think about this crisis and say, from now on, I'm only going to support organizations that do things better, faster, and at lower unit cost. I think we need to be more innovative in trying new private financing, making massive good work, thinking of other ways we could do it. Maybe we could put 50 cents on sports tickets in rich countries. Maybe there are lots of other things we need to think about. But in the future, the real secret is going to be raising large amounts of money and small units from huge numbers of people. When the tsunami hit South Asia in 2004, Americans gave $1 billion, and half of it they gave over the internet. The median contribution then was $56. When the earthquake hit Haiti, Americans gave $1 billion, and they gave massive amounts through the telephones, their cell phones, by just simply typing in Haiti, and there was one number for the Red Cross and one number for Partners in Health, one number for the fund we set up with former President Bush. It's amazing. The Canadians did the same thing. In the U.S., it was an automatic $10 contribution, in Canada, automatic $5 contribution. We've got to do this. And you empower people who can never come to this conference, who are maybe have young children, can't pay their bills, don't work for an NGO, but really are for you. They love what you're doing, and they don't think they can matter. They don't think they can make a difference. If they knew they were part of 1 million, they would happily give you $5 or $10 every now and then. We've got to do a better job of that, and we need help with it. Finally, I think the advocates should continue to advocate. I don't mind the demonstrations. I gave you my best judgment about what the real problem is in America and what the most effective strategy is. But I also think you should remember to educate as well as advocate. Healthcare is not just a right, it's basically an extraordinarily good economic investment with a very high rate of return. Whenever people talk about what we do in healthcare as a development investment, some of the people, like in our Congress and other places, their eyes glaze over. And I find that ludicrous. You know, if you want to build a coal-fired power plant in the United States, by law, the person who builds the power plant can let you pay for it over 20 years on the theory that the useful life of the plant is even more than 20 years. Some states, if you build a nuclear power plant, they let you pay for it over 30 years. If you pay a pittance of that to save a child's life who will then live 70 years, they want you to count it as a cost today without considering the benefit. If these young people lived to be 70 years old, what was it worth to provide their medicine? What was it worth to give them a chance to live full lives? We need to make the argument on real economics, not phony economics. Talking about what health care costs today without talking about what benefits are long run is a huge mistake. Look, I guess what I'm trying to say is you've done great, whether you're advocates or healthcare professionals or workers in NGOs or scientists. But we can do better. We can reduce the number of new infections dramatically. I don't care what anybody says, we can achieve universal access. But we can't do it by walking away. I just, took my annual trip to Africa, as I said, and I was reminded all over again in remote rural places, looking at our AIDS projects and some of our economic projects, that intelligence and ability are evenly distributed, but opportunities are not. In one of our agricultural products, I can hardly talk about this, in Southern Africa, we help people increase their farm yields and then earn a higher percentage of the sale price of their products. So I met with all these farmers, but the one who was the chosen spokesperson was a woman whose husband had died and she had only one child, and her sole source of income was a 1/4 acre of land on which she grew soybeans. Last year she earned $80. So we gave her better seed, better fertilizer, a way to get rid of the pests. She increased her yield 2.5-fold. Then we directly marketed her soybeans to the processor so she didn't have to go through an agent. That doubled that income. So instead of $80 on this little 1/4 acre, she made $400 this year. A 5-fold increase. Why? She didn't do anything different. She had a system that worked for her. Most of us who live in rich countries have systems that work for us all day, every day. We get that kind of return all the time, and we don't even think about it. That woman's kid deserves the same future that our children do, that our grandchildren do. It is not right. That was the first. So I will just close. I'll give you 2 thoughts in closing. A couple years ago, there was a great movie, at least I thought it was, called The Bucket List, with Morgan Freeman and Jack Nicholson. And I know both those guys well, and they had a terrific time doing this. But so Freeman plays a guy who's really sick, and he doesn't have long to live, and he makes a list of everything he wants to do. And he and Nicholson talk about what they want to do before Freeman dies, and they go around these 2 old coots and they do it. I'll soon be 64, so I think I'm old enough to join Jack and Morgan in making a bucket list. But I have an A list and a B list. The B list is stuff that'd be fun to do, but doesn't amount to a hill of beans whether I get to do it or not. I'd like to climb Kilimanjaro before the snows melt. And I'd like to run 1 marathon before I give out. There's lots of things I'd like to do, but it doesn't matter whether I do. What I really care about If I could have my wishes, I'd like to live to see my own grandchildren, and I'd like to live to know that all the grandchildren of the world will have a chance in the not-too-distant future to live their own dreams and not to die before their time. For us, that means replenishing the global fund, helping donors, especially America, avoid the false choice between funding treatment and funding maternal and child health and health systems. It means doing our own business better, faster, with lower unit costs, better treatment, scaled up and targeted prevention. It means a disciplined, honest, non-backside covering way of cutting the cost of delivery and putting more of our taxpayers' money into saving the lives of the people that they appropriated the money in the first place to save. It means better private investment, more opportunities for more people to give. It means educating about why this is good economics. That's a pretty worthy thing. Now, a lot of people are cynical, so this is the last point I want to make. In addition to all the AIDS-related scientific advances in the last few years, just a couple of months ago, there was a stunning discovery coming out of one of America's super colliders in physics, purporting to show the first proven connection between physics and biology, since we are, after all, atomic beings. Now, this will have to be confirmed, I should say, by the superconducting super collider that is about to open in Switzerland, which is the biggest in the world. But the preliminary indications of the American tests broke down all these subatomic particles and may have finally solved one of the biggest problems in physics, which is, how could life have ever begun in the first place, since in traditional theories of physics, positive and negative forces are supposed to have always been in balance. Matter was constant. It may have changed form, but it was constant. How did the spark of life ever begin? According to the subatomic analysis done by our scientists, it turns out that these tiny particles called muons, where according to all traditional physics theory, there would have been an equal number of positive and negative ones, lo and behold, there were slightly more positive than negative muons in every tiny atom, which may explain how we all wound up coming out of the primordial slime. What's the relevance of this to you? That's the only chance we've got. The chance that within us all, the positive is just a little bigger than the negative. I'm betting that it is. Thank you, and God bless you.
Good morning, ladies and gentlemen. It's my great pleasure to introduce our next speaker. He is Secretary of State for Social Affairs in charge of disabled persons, Deputy Minister for Social Affairs and Public Health in charge of social integration. As Belgium is presiding the Council of the European Union, the speech delivered will be on behalf of the European Union. Jean-Marc Delisle, please.
Dear Madam Chair, Mr. President, ladies and gentlemen, and if I may, dear friends, good morning to you all. Let me tell you first, it's an honor for me to address this very important conference at its start. And it's an honor to speak on behalf of the European Council of Health Ministers, currently chaired by Belgium. But it's also a big challenge to speak right after President Clinton, not only because of his eloquence, but also, as it has been said, because he has been very active in the fight against AIDS for so many years. It's a big challenge because I have the impression the most important things have been said and well said. Well, the World AIDS Conference is an important opportunity for our common endeavour to further strengthen the response to HIV/AIDS. We must do it at national and international levels. All partners must be involved: private, public, civil society and international organisations. Today, I reaffirm the commitments of the European Union to play a vital and leading role in the strengthening of this response. At a global level, the trend seems to be positive, but we are not there yet. The World Health Organization estimates that 2.7 million additional people were newly infected with HIV in 2008. The same year, there were 2 million HIV/AIDS-related deaths. This is not acceptable. Those numbers remind us that we need to improve further policies, means and tools. The revision of the Millennium Development Goals next September will clearly mark what still needs to be done and how. HIV/AIDS continues to be a threat to development. The damages to lives, health and well-being of individuals remain dramatic. And it's especially true for women and children. It's important to promote gender equality and empowerment of women. It will help them to say no to unsafe sex and to protect themselves from infections. The health system must integrate HIV services and effective initiatives to achieve universal access to HIV prevention, treatment and care. Strengthening these services is the only way to achieve the MDG goals by 2015. The European Council of Health Ministers reaffirms its strong support to attain these goals. In times of economic crisis, we cannot lean back. The crisis cannot divert our attention. It cannot undermine our efforts in HIV prevention, testing, treatment and care. We must continue to fight HIV at every level in our society. Now, what's the situation in Europe? The European Union and its neighbouring countries are currently facing a particular challenge due to alarmingly high numbers of eye infections. Early diagnosis, treatment coverage, focusing especially on risk population, will be crucial to stop this. Effective, human rights-based HIV policies need to be implemented. The EU communication, Combating HIV/AIDS in the EU and neighbouring countries, and the Action Plan for 2009-2013 put forward coordinated actions of all Member States, the European Commission and its agencies to react firmly and coherently. We need to reduce new HIV infections. We need to improve access to treatment, care and support. We need to improve the quality of life of people living with AIDS. Council conclusions, adopted in November last year, focused on actions to confront HIV/AIDS through external action. They include the need to fully respect human rights, the right of every man to enjoy the highest attainable standard of physical and mental health. All people must have access to information, to early diagnostics, to effective prevention, and to treatment options. Political leadership is crucial for an effective response to HIV. All European institutions have shown their commitment. But the European Union cannot do this alone. A close collaboration with international organizations and with civil society is absolutely necessary if we want to reach our goals. Let me now recall three crucial elements. First, prevention and screening. We must promote and scale up prevention efforts. This means improving information for all, especially young people who have missed the former successful HIV communication campaign. It means paying special attention to risk groups with a high prevalence of HIV. We must fully inform them of prophylaxis, HIV testing, and the treatment options available. The biggest impact on the epidemic can be achieved when the situation of the population most at risk is addressed efficiently. Key populations at risk must be recognized. Their voices must be heard. Their needs must be met. This is relevant for all men and women, children and young people, regardless of their HIV status, sexual orientation, age, gender, ethnicity, or any other status. Tailor-made approaches for key groups are essential in containing the epidemic. The second crucial element is to reduce stigma. Particularly concerning is the high number of persons who are not aware of their infection. About 30% of people in the EU and up to 70% of people in several neighboring countries are not aware of their HIV status. This presents a serious concern for policymakers. And rightly so, because late diagnosis usually leads to late treatment and hence to a reduced life expectancy, a lower quality of life, and to an increased danger of transmitting the virus to partners or babies. We have to scale up screening and diagnostics. We have to overcome the stigma. We have to do more to ensure that people can be tested in all serenity and security without being blamed or questioned afterwards. People living with HIV are often still too frightened to come forward for help because they are afraid to be stigmatized. Promoting full adherence to human rights, the right not to be subjected to stigma and discrimination must be guaranteed. The third and final crucial issue I want to talk about is access to treatment. Economic operators and public authorities should cooperate to improve the provision of safe and affordable antiretroviral medicines to people in need. We need to strengthen our health systems, include HIV programs as broadly as possible, and make medication available to all. Local, public, private, and community-based services must be supported to achieve universal access. These two words are certainly the key words in this issue: universal access to HIV prevention, treatment, and care. Exchange of good practices on prevention, testing, treatment, and care between countries is also very important. This is especially beneficial in times of budget constraints. The cooperation and exchange of know-how between doctors, nurses, and public health experts, as well as sharing quality data, will help to improve evidence-based prevention, state-of-the-art testing and treatment services, and to improve surveillance. Such joint efforts will reduce new infections, improve the life of people living with HIV/AIDS, and underline the value of good cooperation between neighbors. Ladies and gentlemen, as a conclusion, we can affirm that we have improved our reaction to the epidemic. This is certainly positive, but this gives a false feeling of security. The threat remains for everyone and will last. Millions infected are not mere statistics. Behind every number is a human being who needs our support because she or he is fighting a disease that is still threatening all of us. A lot has been done, but we still have a long way to go. President Clinton said another way, this is the end of the beginning. Right here, right now, yes, you're right. This is a cause for solidarity. Let's continue this fight together. I thank you for your attention.
Good morning. It's now my pleasure to introduce Viseka. It's my pleasure to introduce Viseka Dubella. Viseka is the General Secretary of the Treatment Action Campaign, where she founded several branches and programs. She has served as a member of the Treatment Action Campaign since 2001 and was elected to her current position in 2008. Viseka is committed to ensuring that people living with HIV have a strong voice in the struggle, and that especially girls and women have access to health services and equality in a society free of gender and sexual violence. She is the national representative for the people living with HIV in the South African National AIDS Council and the chairperson of the AIDS Law Project and a member of the Global Task Force on Women, Girls, Gender Equity, and HIV. She is presented and published in multiple national and international health and human rights conferences and was nominated recently as one of Mail and Guardian's 30 young South Africans to have lunch with. Viseka holds a BA in Health Services and Social Services from the University of South Africa. She is currently completing her honors in psychology from the University of South Africa. She will speak to us this morning on positive health, dignity, and prevention. It is my great pleasure to welcome to the podium Viseka.
Good morning. I'm really impressed by the room being filled in such an early time of the day. And already, as you heard, I'm going to be speaking about positive dignity, health, and prevention. But comrades, colleagues, ladies and gentlemen, and all protocols observed, I'm very honored to be speaking before you and very proud to be South African, to speak today and stand before you after such beautiful words said by my Deputy President, Kgalema Motlanthe, yesterday, emphasizing that the economic challenges that we all have should not be a barrier to scale up prevention treatment services, because otherwise we will have much deeper, serious challenges on development. So development in AIDS is a development in economy as well. So my focus today is going to be what we have achieved between Durban in 2000 and now in Vienna, and why that we cannot retreat today. Also explain this new paradigm on positive health, dignity, and prevention, and universal access to treatment, but also talk about a little bit about treatment as prevention. And all what I'm going to be presenting is centered around what is the role for people living with HIV and how we want to be seen as part of the solution. But also I want to highlight, and I'm very happy that some of my messages are going to be delivered by people who are, some of them are in the panel. The member of parliament from from Belgium, I have a message for the European Union. I'm happy that if you can take that message. Also to address issues around discriminatory laws, around human rights, very strong issues around women and girls and HIV and inequality. So, we are here today marking 10 years since Durban. Today, we are now talking about, at least we have saved 5 million lives, and that includes my life. I had the privilege to start treatment in 2004, and now I'm 6 years on treatment, and thanks to access to affordable, cheap generic drugs. And because we all know that this is not enough, we know that we have only saved half of those that we need to save. There's still more that we need to do. We're only covering 50% of the need. And also because of continuous pressure from activists and people living with HIV, drug prices have dropped. We now have access to much more cheaper drugs. We can still do more. I don't need to repeat the statistics on the presentation, because we all know that we still are faced with a growing epidemic. It is starting to stabilize in some countries. It's not yet clear whether it's stabilizing because of death or we actually are making progress. But also, my biggest concern is the fact that still new infections are still happening in high numbers amongst young women and amongst young people. At least 50% of people living with HIV globally are women, and at least 40% are young people. And in my region where I come from, we still represent 67% of the global HIV, people living with HIV. So we carry the burden. So, because I'm asked to speak about, and I have to speak about this paradigm, and other people are going to be asking, so what is this positive health and dignity and prevention? It's complicated. We just heard about treatment 2.0. There's just too many new paradigms. What is this positive health and dignity? As you may remember, that in 2001, we started hearing about the role of people with HIV in prevention, and it was called positive prevention. And basically that paradigm was talking about people living with HIV being seen not just as transmitters, but also people who can also contribute towards prevention. And today we have expanded. We had consultations with global networks of people living with HIV at national level and at a global level to define what do we think is the new shift, because there's much more that people living with HIV can do and still need today that is not yet encompassed in positive prevention alone. So this new paradigm is a shift designed by people living with HIV, but also led by people living with HIV. And its aim is to support people living with HIV with their prevention needs, with a special focus on improving and maintaining all aspects of health being and of our health and well-being. And in turn, this contributes to the health of our partners, our families, and our communities. And human dignity symbolizes respect and value for people living with HIV, and it is enforceable. And therefore, there can be no exceptions. We need to combine positive health messages with messages and actions towards human dignity and respect. And at the core of this paradigm of positive health, dignity, and prevention, it's about policies, programs that treat people living with HIV humanely and holistically to enable us to protect ourselves from HIV and also to protect others, not through fear and coercion, but through empowerment and dignity. And policies and programs that recognize comprehensive experiences that needs of people with HIV are much more likely to have greater acceptance from people living with HIV, which in turn is much more likely to benefit public health. We have to remember that prevention is everyone's responsibility. People with HIV don't have only because they live with HIV have that responsibility. So it's everyone's responsibility to prevent new infections. Therefore, we must share that responsibility. The importance on ensuring that people living with HIV have access to preventative services remains critical. People need to have access to treatment and prevention tools and services that respect their human rights, including sexual reproductive rights of women and gay men and gay women, that promote gender equality and that provide social and economic empowerment and support. Hence, universal access to treatment, care and support remains a critical goal. There is progress. Yes, it has been painted yesterday in the opening session and this morning, and there is hope on universal access. Therefore, now is the time to accelerate efforts to prevent new infections, and this is not possible if we do not consider the following. Universal access remains a catalyst to support and realize the number of other MDGs. Besides just MDG 6. Achievement on the other MDGs will also play a critical part in achieving positive health, dignity and prevention for people with HIV. So governments must recommit to universal access and achievement of MDGs to ensure that sufficient resources are made available to reach these goals. We need to address the human and financial resource challenges to meet these targets on treatment and MDGs. The current trend on non-accountability in efforts towards universal access and the Millennium Development Goals by African governments and global leaders is unacceptable. We urge all our global leaders to fulfill their commitments by replenishing the Global Fund to fight HIV, TB, malaria at least by $20 billion in October this year. This is at least, I re-emphasize, we need more. Universal access is not about 60%. Universal access is not about 80%. Universal access is about 100% coverage. We also demand that our African governments must honor their commitment they made in Abuja by spending at least 15% of their national budget towards health. This is not an aspirational target, as our African ministries of health have declared in March 2010. This is an investment in positive health, dignity and prevention. And we know, we have seen in South Africa during the FIFA World Cup that it is possible to have resources to build very nice stadiums, which we do appreciate. So it is also possible to reach the Abuja Declaration. I think we also demand that the private sector must take a responsibility in this epidemic, beyond just corporate social investments. And this can be done by supporting the financial transaction tax to fill the gap on resources for health. They need to pay back the money that they were given by governments during the economic crisis. Now is their time that they are making profit to give back that money to resources for health. And we continue to ask our president in South Africa to continue to be the champion for universal access on the G20 on behalf of the continent. Now, combination prevention is very important, and many of us have observed and participated in debates over the past year on treatment as prevention. Treatment as prevention is an important part of combination prevention. It provides us with an opportunity to think about preventative effects of antiretrovirals and how we can scale up. Beyond treatment as prevention, and other important elements of combination prevention include harm reduction measures, the reduction of multiple partners, prevention of vertical transmission, male circumcision, structural interventions, and ensuring human rights. Key to combination prevention is also the research and development for new HIV technologies such as microbicides, PrEP, and vaccines to prevent new infections. Communities continue to express caution and warning for the respect of individual human rights in relation to access to treatment and testing, not to impose coerciveness, stigma, and discrimination in health facilities. While we don't have enough evidence about how test and treat will unfold, at which CD4 count is the right time to start, however, we're looking forward to the trial that is done by the START trial that will provide much more evidence to tell us in terms of what is the best time to start treatment. I also want to highlight some of the challenges that we need to start at. Now, this is the message for the Member of Parliament from Belgium. I am very happy to be sitting next to you to deliver this message personally, that the current European Union's negotiation on free trade agreements that pushes for longer patent terms, for harsher intellectual property enforcement measures that violate civil and political rights and threatens the production of cheaper and affordable medicines must be radically changed. This threatens developing countries' ability to import and export medicines. These new monopolies on medicines threaten the feasibility of developing countries to continue to have access to cheaper generic versions to achieve universal access. So also, we know that there's a secret treaty on anti-counterfeiting, reportedly supports the drafting of national laws on counterfeiting. The most fundamental problem about this treaty is classifying generic medicines as counterfeit. That is false. Now, on human rights, I'm sure you already expected me to say I'm not going to keep quiet about what is happening in Uganda and Malawi. Modern law explicitly promotes human rights and gender-sensitive approach to HIV-related legislation. And this aims to ensure that human rights of those vulnerable to HIV, people living with HIV, affected by HIV, are respected, protected, and realized in their responses to AIDS. It is important to note that 84 out of 136 developing countries of UNAIDS reported having laws and regulations that present barriers to effective prevention, treatment, care, and support for vulnerable populations. Both the African Union and SADC have drafted a number of codes, guidelines, and protocols since 1997 that are meant to protect human rights of people living with HIV. And the AIDS Alliance Rights of Southern Africa has reported that major concern for legislators in SADC shows a continuing trend to address these concerns in a way that undermines human rights of people living with HIV. And I want to mention what I am talking about. One is criminalization of HIV transmission. Still today, we are talking about universal access. Universal access, it is not possible if you do not have a legal framework that allows people to have access to services. Still today, European countries still impose laws that criminalize HIV. In Africa, West, Central, and Southern Africa still are busy enacting and proposing laws that impose criminalization. And two, we are still criminalizing same-sex relationships. There is a growing number of countries that continues to criminalize homosexuality. For example, what we have seen in Malawi and Uganda, and we still expect gay women and gay men to go out there and access services under this condition. It is impossible and it is unacceptable. Again, criminalization of sex work. And unfortunately, sex workers all the time gets to be forgotten. And we had a very hot debate during the World Cup in South Africa, whether we should decriminalize or not decriminalize sex work. And why that debate only becomes very hot when there's World Cup, I still don't know what is the rationale behind that. Because for me, sex workers are exposed to violations and brutality every day. And therefore, decriminalization needs to happen today so that sex workers can be free to work in the industries that they can work, but also they can be able to access services where they need to access services. And most of African countries as well, they know that most of vulnerable groups in their countries are sex workers, but they cannot even name them in their national strategic plans. They don't exist, but they do acknowledge that they contribute towards the epidemic of the country, but they don't have any plan to address them. And therefore, we must push for legislation and public health policy to protect vulnerable groups and expand access to treatment, prevention, and care, so that groups that often are unable to access health services and justice services are able to access them. and I want to name them. Lesbian women, because they get to be forgotten. Hate crimes against lesbian women, they need to have access to justice services so that they can be protected. Men who have sex with men, transgender persons, prisoners, foreign nationals, mobile populations, migrants, refugees, sex workers, and people who use drugs. These names are not difficult. They can find their way in their national strategic plans. And these are people. We must not forget to put pressure on the Iranian government. It's been 2 years that Dr. Arash and Dr. Kamil have been arrested on their work on AIDS. We can no longer keep quiet when we are talking about human resources for health, but 2 doctors are in jail for working on AIDS. It's not a crime to treat AIDS. Another issue is on women and girls and HIV. Women in my region constitute more than 50% of those living with HIV. And they are particularly young women who are most at risk of HIV transmission. Till today, we have very limited preventative tools that women can own and that they can protect themselves from the risk of infection. And the most challenging issue is the violence against women that has become a human rights crisis of our time. Countries in Africa still forcefully mutilate women, and these practices happen in communities throughout the world. Violence continues to impose a lifelong threat to young women. This is increasingly alarming and poses this public health crisis. And statistics on violence against women and girls have become so common that we have forgotten that there are people behind these statistics. That is why I think we underplay the role played by violence in the epidemic. That is why we have very little investments to address it. For example, in Zimbabwe, during the political unrests, violence against women was used to intimidate women for political reasons, and more than 800 women were raped. This is a crime against humanity. We all have to take a global responsibility to raise our voices to ensure that African and international communities can prevent this from reoccurring. By the way, Zimbabwe will have elections in the next 2 years or year. Well, how are we going to make sure that this does not happen again, or raise our voices that it does not happen again? And again, societal attitudes against women needs to change fundamentally to respect women's equality, freedom, and dignity. The last thing I want to talk about is social inequality. We also have to pay attention to the social inequalities that contribute to the factors that drive the epidemic. Although I come from a country that is regarded as an emerging economy and the only middle-income country in the G20, but South Africa has the highest number of people living with HIV. It has the highest levels of unemployment. People live in poverty, millions live in poverty. We also have faced with reduction in life expectancy because of HIV. So inequality between the rich and the poor in the same country has led us a status that is unfamous. We are now number 1, the most unequal country in the world. Let's compare ourselves to the country that is hosting us. The country that is hosting us has earned itself a status as in the top 5 countries of the world's best quality of living. It's a home to the greatest classical composers of our time. It has nice palaces, museums, and churches. Yet I wonder, I want to ask a question. How much does the Austrian government contribute to fund the fight against HIV? Where is your global solidarity? What is your commitment to the Global Fund? In conclusion, human rights here, human rights now, means we cannot go back. Hope has just started. However, I want to leave us with food for thought. It's time to support the leadership of people living with HIV and work with us and be accepted as leaders that we all can work together to realize positive health, dignity, and prevention. Also, socioeconomic and human rights are non-negotiable. If we don't respect these rights by holding our governments and global leaders accountable for all our causes, history will judge us. We must re-energize. We must recommit to achieve universal access. We must defend our gains and speak the truth to power, because health is a global public good. Amandla! Good morning. It's a pleasure for me to introduce Anya Sarang. Anya Sarang is president of the Andrei Rilko Foundation for Health and Social Justice in Moscow, where she works on advocacy for access to health and protection of human rights, as well as dignity for people who use drugs and for humane drug policies. For the past 11 years, her work has focused on developing and supporting the emerging harm reduction movement in Russia through various activities in training and networking activities. It's a pleasure to have Anya Sarang with us.
Thank you so much, Nora, and good morning, dear friends. It's a big honor for me to address such a large auditorium full of my fellow activists, scientists, doctors, health workers, politicians, officials, and all of you who work in HIV. In just 20 minutes, I have to share with you our experiences, our frustrations, and our aspirations. And I know that for many of you, the term harm reduction is not as familiar and important as for those of us who work in countries where people continue to suffer because of war on drugs. For some, our fight may seem small and less demanding than the situation in other parts of the world, where HIV hits a larger proportion of people, not only or mainly drug users. On the surface, advocacy for evidence-based and humane drug policies may not seem immediately relevant to the public health preventing and treating HIV. In the short time, I will have to explain why drug policy and human rights are so relevant and important to all of us. And I will start with a personal story, not because I think that my life is so important and illuminating, but because that's what I know best, and because I think that in every life we can find reflections of lives of others. I know that for many of you, the start of your work in HIV was connected with loss. Too many of people who are here have lost their friends, their close ones, their loved ones, their neighbors to AIDS. And that's what pushed many of us to commit your lives to fight with the disease, to building better health care in your countries. This was totally not my situation. When I started to volunteer in one of the first outreach projects in Moscow, Russia, back in 1997, none of us in the outreach team knew anyone who had HIV. When the first of our clients, a homeless drug user, Sasha, got his HIV-positive diagnosis, it was a huge shock for all our team. Some people had to go through psychological counseling to just accept the fact that they knew someone positive. I remember back then I was reading a newspaper in Moscow which said that there were about 100 new infections in my city of 15 million people. The epidemic was really small. It seemed something distant, something irrelevant, something from another planet. But still, we did HIV prevention outreach. We had a great team of peer counselors and provided training for drug users. It was really one of the best teams, and it did great work. The only thing we couldn't do was something that we needed most. It was provision of clean needles to drug users. Despite overwhelming international evidence that needle and syringe programs prevent HIV, the Moscow authorities were categorically against them. Medicine Sans Frontiers, who operated our projects, were threatened by the authorities with expulsion from the country if they started to provide clean needles to people who needed them most. And so we didn't. Today the situation in my country is the same, but also different. The same in the way that the Moscow authorities still religiously oppose needle and syringe programs. The same that despite decades of strong evidence, these programs are operating at very low scale. The same in the way that HIV prevention and outreach programs in my country still operate under the threat of closure. But different in a way that now I only have a few friends who do not have HIV. HIV prevalence among drug users in some Russian cities reaches 75%, and almost 1.5 million people are estimated to have the infection throughout the country. In Moscow, the city whose health authorities claim success in fighting the epidemic, every 3 hours a new person gets the official HIV diagnosis. When the conference organizers invited me to deliver this plenary in spring, I was just rereading Timequake, a book written by one of the greatest writers and humanists of our times, Kurt Vonnegut. In Vonnegut's fictional Timequake, the universe suddenly suffers a crisis of conscience. Should it keep expanding or shrink back? It decides to take a pause and back up, making everybody and everything do exactly what they've done during the past decade, for good or ill, a second time. It was déjà vu that wouldn't quit for 10 long years. There was absolutely nothing you could say during the rerun if you hadn't said it the first time through the decade. You couldn't even say your own life or the life of a loved one if you had failed to do that in the first time through. So people had to repeat their lives the hard way, minute by minute, hour by hour, year by year, betting on the wrong horse again, marrying the wrong person again, getting the clap again, you name it. When I was reading this story, I was always imagining my own Timequake, how unbearably hard it would be to relive the past 15 years that I worked in the AIDS field, knowing what is going to happen, but not being able to change anything. The memory brings me back to moments that was so hard to live through, and moments that are alluring in their beauty. The first thing that flashes in mind is the 14th International Harm Reduction Conference in Chiang Mai, Bangkok, Thailand, back in 2003. Just several months prior to the conference, the Thai government decided to toughen its war on drugs. It's good to fight drugs, isn't it? And so the Thai Prime Minister gives instruction to the police that people charged with drug offenses should be considered security threats and dealt with in a severe and ruthless manner. Any means in this war will do. The police take their instructions seriously and start to shoot people on the street on mere suspicion of drug sale. So there we are, in the middle of this terror, a community of international harm reduction activists totally outraged with the acts of police and with the Prime Minister, but completely paralyzed in inaction, as there is this fear that our loud advocacy can hurt even more. I came to the conference together with my friends and my ex-husband, drug user activists from Russia. At the conference, they were not provided access to substitution treatment, as Russia still stands alone in its federal ban on opiate substitution. So left without medical support, my friends have to get out on the streets of Chiang Mai to get heroin. And all I do throughout the conference is wait and fear and wait. Don't worry, somebody tries to cheer us up. They only kill Thai junkies. I live through this again with the same feeling of terror, unable again to do anything to challenge the Thai government, even that I know that in just several months after the conference, the estimates of people who were just shot on the streets will go almost to 3,000. Later, in the reports of human rights organizations, these killings were referred to as extrajudicial, as opposed to judicial killings in countries like China, where the UN World Anti-Drug Day is marked with executions of drug offenders sentenced to death in front of crowds chanting, "Kill, kill." Last month, over a dozen were killed to mark the day. You may ask how these executions and cases of police brutality relate to HIV, and many governments still don't get it. So let me ask you this question. If you were a drug user surrounded by violence and abuse aimed squarely at you, would you raise your head above the parapet and come forward for testing or prevention services? HIV prevention and treatment programs will never be effective at their full potential when human rights abuses are rife. It's as simple as that. Years of experience have taught us this painful lesson. Fear of arrest, detention, and even assault feeds HIV risk and hampers HIV prevention and access to treatment. Thankfully, as my time quake continues, I can move on to the happier moment of the next International Harm Reduction Conference of 2004 in Melbourne. Just 7,000 kilometers away from Thailand, Australia have proved to the world that scale-up of provision of sterile needles in combination with peer education and substitution treatment, and later safer injection rooms can really stop HIV. Australia started to implement country-wide harm reduction programs at very early stages, and till today, less than 1% of people who use drugs are infected with HIV. It was also one of the first countries where drug users organized into a national league and demonstrated that meaningful involvement of affected communities plays a crucial role in halting the epidemic, shaping national health policy, and building better services for drug users. This conference was the happiest for me, as I received the International Rollstone Award from the International Harm Reduction Association for my contribution to the development of harm reduction in Eastern Europe and Russia, something that I had to convince myself to accept, and 6 years later, I still don't feel like I deserved it, as my country is still one of the worst in the world in regards to its harm reduction policies. In my personal timequake and this happiest moment in Melbourne, I am greeted by my dear friends and colleagues from all over the world. Among them, Kamir and Arash Alei, the great harm reductionists from Iran, who pioneered the triangular clinics, offering patient treatment with substitution medicine for drug addiction, antiretrovirals for HIV, counseling and treatment of sexually transmitted infections, as well as clean needles and condoms. Their work, like work in other regions before, clearly demonstrated that drug users can very well adhere to antiretroviral treatment if provided with all necessary support and services tailored to their needs. In my timequake, I'm so happy to see them again, as in reality, it has been several years now since I last saw them. No one has. Just a little over 2 years ago, the Alei brothers were arrested for alleged conspiracy against the government and sentenced to 3 and 6 years imprisonment. Their trial was a politically motivated mockery of justice. While many human rights activists and medical professionals have called upon the Iranian government to release them, the brothers are still in prison, and we all hope that this conference can make another strong statement to support them. The LA brothers The LA brothers are not the only public health professionals working in the harm reduction field that have been convicted on political grounds. Many of us were shocked once again with the recent story of Maxim Popov from Uzbekistan. Maxim was convicted for charges including the distribution of harm reduction and safe sex educational materials. The government said the materials were offensive to Uzbek values, and Maxim is now imprisoned for 7 years. The efforts of the international community, and especially the international donors, to liberate Maxim, as well as the LA brothers, are very humble and reserved indeed, despite the fact that we all realize that in totalitarian countries, anyone, anytime can be arrested and sent to prison without due process or even hint of a just trial. It can be any of us. But the situation gets even worse. In many countries, even formality of courts is not required in order to deprive people of freedom. In countries of Southeast Asia and China, over 500,000 drug users are locked into long-term labor camps for mandatory treatment without their agreement, without adequate medical care for those who have HIV, just by a positive urine test. This is not treatment. This human rights violation continues in a country where international organizations and UN agencies support the governments to fight AIDS among drug users. How can that be happening? It seems that drug users are not genuinely considered as humans, and so the concept of human rights doesn't apply. We all know that HIV comes with stigma. Drug dependency comes with such stigma that is hard to comprehend. Drug use has become a label that provides the authorities with justification to act as they see fit, however unthinkable the acts may be: direct or indirect killings, torture, deprivation of freedom or health or dignity. They all will go with impunity. At home in Moscow, later still in my timequake, I read in amazement the minutes of the meeting describing how the Russian health minister, Tatyana Golikova, stands before our president in 2009 and says that according to evaluation of her ministry, needle and syringe programs in Russia proved ineffective, and therefore the ministry will not support them. This is amazing because just a year before, the same minister stood in front of the participants of a regional AIDS conference, promising that the government would fund the programs, prevention and treatment that were previously supported by the Global Fund, including 80 needle and syringe programs. Unfortunately, she lied both times. The Russian Ministry of Health have never done a scientific evaluation of effectiveness of needle and syringe programs, nor on substitution treatment programs that they deny, and has never considered the wealth of international evidence on this matter. And today the Russian government doesn't provide any funding for HIV prevention among drug users or other vulnerable groups. The theme of this conference is right here, right now. So let's talk about here. Vienna, the home of the international drug control system. Despite the Russian government's inexcusable neglect of HIV among people who use drugs, its appalling human rights records, and its effort to impede harm reduction on the international stage, a long-serving Russian diplomat, Yuri Fedotov, has just been appointed as the head of the United Nations Office on Drugs and Crime. It is the lead agency within the UNAIDS family for HIV among injecting drug users and prisoners. We hope, indeed we ask, that Mr. Fedotov rise above Russia's policies and publicly announce his and his agency's commitment to harm reduction and human rights in his first days in Vienna. One last moment that I live through again in my timequake is the death of our friend, Russian HIV activist Taya Suslova. Taya was one of those brave activists who fought for HIV treatment in Russia. She was one of those activists who chained themselves to the doors of municipal governments in Kaliningrad and St. Petersburg when HIV treatment was already available and just not provided to drug users who were regarded as socially unproductive. Front aides fought with the slogan, "We will live, this is our policy." Just a couple of years later, HIV medicines became more available in the country, but Taya's life wasn't saved. She died 2 years ago, in July 2008, of tuberculosis. Since she could get a bed in a TB hospital, but not the necessary support and treatment for her addiction. Since in our country there is no methadone or buprenorphine, she couldn't stay in the hospital long enough to be successfully treated. Reliving this once again, I cannot stop Taya from dying, like I couldn't do it on the first run. We could have made an effort and get her to a country where substitution treatment is available to TB patients and where she wouldn't die at 36 years of age, mother to a 12-year-old son, of a totally curable disease. But there aren't many places in our region where this is true, and as always, we wait too long before we act, and we count on others and miracles, and we don't believe that our friends can die until it happens. And each time it happens, we realize that we could have done something differently, promptly, more effectively, but we cannot reverse the time. In Vonnegut's book, when the timequake is over, free will kicks in again. At that moment, people stop being robots of their past and stop running obstacles of their own construction. At the end of the timequake, when people resumed control, many were depressed and gripped by apathy. Only the hero of the book is optimistic and helps revive others by telling them, "You were sick, but now you are well, and there is work to do." So, to all of us, we are sick, but we can get better, but there is much work to do. Barriers to halting the spread of HIV are obstacles of our own construction. We can tear them down. But just as before, when HIV treatment was not available, we have to fight. For each life, for each policy change, for each human right fulfilled, we have to fight. Nothing will come just by itself. We have enough knowledge, resources, and medicines to provide treatment and support, good quality of life for people affected. But do we have enough courage to challenge the governments who decrease funding to fight the epidemic and break their commitments? To challenge the authorities who refuse life-saving medicine to our drug-dependent friends? To confront those who tell us to turn away from HIV? To remember that we can resist. We can resist because we have the power of knowledge. We know perfectly well how to prevent HIV, and we are learning more each day on effective treatment. We know how to cure tuberculosis and to put services in one place. We know that a $1 shot of naloxone can prevent someone dying of overdose. We have all the evidence for effective drug treatment and better drug policies. We can resist because we have the power of communication. Today, information spreads with the speed of light, and what happens in one part of the world becomes known immediately everywhere. We can transfer technologies and best practices. We can network and influence. Even the language is not a barrier anymore. We can resist because we have the power of unity. We are all affected with one problem, and it doesn't matter where it comes from. People who are stigmatized for their HIV status can easily understand people who are stigmatized even more for being drug users. And this stigma is not only the weakness, but also the strength of our community. It gives us the power of solidarity. We can resist because we have the power of love. Love for our friends, those who passed and those still alive, those whom we remember and those whom we don't want to lose. The power of love that keeps us together and gives us strength to carry each other and keep our fight. And just like 10 years ago at the AIDS conference in Durban, where the world stood up for access to AIDS medicines, we now have to stand up for our human rights. We have to speak up for better drug policies that don't kill or harm people. Many of us have done this by proudly signing the Vienna Declaration. And now, a decade after the Durban conference, we know that we can do it. And just like AIDS drugs became better, cheaper, and more available, we have to make human rights a new essential medicine for all. As now we know that without respect to everyone's human rights, the medicines and our prevention efforts won't work. We need to be very clear. Health systems don't work if people are afraid to use them. Prevention won't be available. Lives won't be saved. Like the Durban Declaration led to access to HIV treatment for many who needed it and culminated in the call for universal access by the UN General Assembly, this conference and the Vienna Declaration must be the call to end the war on drug users. It must be the call to place human rights and evidence-based approaches at the front of HIV fight. We started out by mentioning that in my life, as in every life, we can see reflections of the lives of others. My timequake speaks of my personal story, but it also speaks of others, as well as of political condition. We cannot reverse time, but we should have the courage to build our future in the right way. I don't think we in the AIDS movement lack that courage, but when it comes to drug use and the war on drugs, I fear we have not yet drawn the necessary conclusion. My own timequake has led me to draw many. I ask you this week to listen, share, understand, and draw your own. Thank you.